Good evening. Thank you, Fergal. Having a baby is probably the biggest life-changing event that you will ever experience, and it can be a wonderful, exciting time. However, having a new baby brings some challenges. And these changes of having a baby are physical changes, so that's changes as you recover from birth. So your body's recovering from birth. You've got emotional changes as you adapt to becoming new parents. You've got social and relationship changes. And all of these changes can bring challenges. Now, as a midwife, I've been asked here to talk to you about the common postnatal challenges. And I've thought about this a lot, and I've decided not to talk about the big challenges that we would see in the postnatal ward, like postpartum hemorrhage or postpartum sepsis. I think it's more appropriate to talk about the challenges that we would pretty much every woman will experience, and really with the aim of trying to help women to negotiate this journey, to maybe avoid the challenges or certainly reduce them, and maybe prepare for becoming parents. Also, if challenges do exist, to know how to recognise them and what type of help or treatment is available. So 15 to 20 minutes is a short time, but I am hoping that I will talk about fatigue and tiredness, pain, some breastfeeding challenges, urinary incontinence, and the baby blues of postpartum depression. So to begin with, tiredness. I think that everybody would agree that when you have a baby, you expect to be tired. You're tired because you're recovering from birth. You're tired because you're mentally exhausted on a very steep learning curve, learning how to feed and change and settle babies. But most of all, you're tired because newborn babies will only sleep for very short periods of time, 2 to 3 hours at a time. So we would say that it's really important that new mums learn how to sleep when their baby sleeps. This sounds like a very simple thing, but it's actually not the easiest thing to do. We call it the power nap. So we would say when you have a new baby, go home and learn how to feed and change and settle your baby, and then maybe have something to eat yourself, and then maybe go for a walk, but try and get your 20-minute power nap before the baby is due another feed. The next thing with tiredness is nutrition, because nutrition is our fuel. And unfortunately, when we're tired, we don't have the energy to really think about what we're eating, and we tend to maybe eat foods that have low nutritional value. So we would encourage women to have high protein and high vitamin C in their diet, which is going to promote healing, high iron, which is hopefully going to build up your iron stores because you lose some blood after having a baby. But it is a basic healthy diet. Plenty of fresh fruit and vegetables, looking at your meat, looking at your food pyramid in general, and plenty of seeds and nuts, and maybe choosing the healthier carbohydrates, so you're talking about whole grain rice and pasta rather than our white rice and pasta. But nutrition is important, and these are things that you can really plan for before your baby arrives, maybe cooking nutritious meals and freezing them, because a new baby takes up a lot of time. I think the other thing that's important is encouraging women to exercise, and this sounds like a contradiction in terms, because if you're tired, do you have the energy to exercise? We would say small amount of exercise is really beneficial, and it will actually boost your energy levels and reduce tiredness. Now, we're not talking about training for a marathon here. We're talking about, a short walk in the park with the buggy, maybe 15 or 20 minutes per day. And I think the most important thing to say is to try not to be superwoman, and to expect that you're going to feel tired and to take the rest. And, let some things slide. The most important thing we say is to have a healthy mum, a healthy baby, and a healthy partner, and let everything else follow. So the next point we're going to make is a challenge that every woman will experience postnatally is pain. And pain is not your friend. Women who are in pain will have a slower postnatal recovery. They are less likely to move around very well, and this increases other risks of things like clots in the legs and clots in the lung. And also pain interferes with breastfeeding. If you're in pain, your body won't allow you to release or let down your milk. So all women, as I say, whether you have vaginal or caesarean section, will have some level of pain. If you've had a vaginal birth, we would say you would be expected to have some bruising and swelling in the perineal area. You may have stitches. These tend to be dissolvable sutures that don't need to be removed. But to manage the pain then, good hygiene is important to reduce the risk of infection, but the actual process of providing the hygiene, as in douching down, is comforting. In the first 48 hours, we would encourage women to use ice packs because this can reduce the swelling. But most importantly, we encourage women to take pain medication. And from my experience, when I worked on the postnatal ward, I would find that many women would say, oh, I won't have any pain medication, because they were, I suppose, primarily concerned if they were breastfeeding that they were giving their babies the pain medication also. But the medication that we choose are suitable for breastfeeding mothers, and it is much more important that you are pain-free. If you have a caesarean section, it is major abdominal surgery, and you definitely will have pain. So we would say it's really important to take your pain medication regularly. And because of the location of the wound, the lower abdominal wound, our physiotherapists come around and they show women how to get in and out of bed correctly to reduce the pressure on the wound. So that is important. But I suppose to say to everybody, pain is normal to an extent, but if it is very severe, if it's persisting, we'd say it's important to have a medical review, and that would be to reduce the risk that you have developed maybe an infection or maybe a collection of blood known as a hematoma. So moving along, talking about breastfeeding, and that's a photograph of a beautiful baby attached to the breast, very nicely attached and very relaxed and chilled out, and this is what we are aiming for. The World Health Organization states that breastfeeding is best for babies, and it is the best nutrition for babies, but it's not only nutrition, it can help in the behavioural and emotional development of the baby, and breastfeeding contributes significantly to the future health and well-being of babies and their mothers. So we really encourage breastfeeding. However, as a mum and as a midwife, I would say that breastfeeding does come with some challenges, and we need to be prepared for these. First of all, mums are learning a new skill when they're breastfeeding their baby. Their baby is also learning a skill. We need to become confident that the baby is thriving, because our breasts don't come at millimetre level. So when we're breastfeeding, we don't know exactly how much the baby is getting. We also have some cultural challenges, because in the generations above us, they may not have breastfed babies. So our mothers, our aunts, our mother-in-laws may never have breastfed a baby and don't understand what are normal breastfeeding patterns. And they may not be as supportive in that, thinking that the baby is hungry if they're feeding regularly. So that can also be a challenge. And then we have physical challenges. And women can develop things like cracked nipples, engorged breasts, mastitis, and the baby can have something like a tongue tie. But the good news with a lot of these challenges are that they can be prevented or avoided or maybe reduced. So we would say that in order to reduce the risk of breastfeeding challenges, education is so important. We would say attend antenatal education classes, attend breastfeeding workshops if you can. In the Rotunda Hospital, we run a free of charge breastfeeding workshop for our mothers, and this is a really practical session where mothers are actually given baby dolls and shown how to position the baby at the breast, shown what a good latch is like, knowing what normal feeding patterns are like, knowing what problems can arise like cracked nipples, engorged breasts, and how to manage these. We also talk about the importance of having your support set up before you go home. When you go home from hospital with a new baby, you're tired and you really don't have the time or energy to start seeking out what supports are in your community. So we ask our pregnant women to go and do some homework. So to find out where your local Lalesh League is, find out where Quid you are, find out where your local health centre is, and contact these people and actually maybe go and visit support groups before your baby is born, so you know exactly where they are located. The other important thing, of course, is to educate your partner and your mother-in-law and your mother as to your intention to breastfeed and the normal breastfeeding patterns. And there's some lovely leaflets that the HSE produce with regard to this. There's also another wonderful resource, and it's the HSE website on breastfeeding, and it's www.breastfeeding.ie. And this website has been recently revamped, and it's got some lovely videos and an excellent resource. But I think in preparing for breastfeeding, we need to have realistic expectations. We would expect that a newborn baby will feed somewhere between 10 and 12 times in a 24-hour period. And a feed can last anywhere between 10 and 40 minutes, and even sometimes longer. So this is a lot of time sitting down feeding your baby. But I would say to every woman, know that this is not only nutrition. This is really precious time for your baby. When they're lying skin to skin, they're hearing your heartbeat, and it's really reassuring and calming for the baby. But it's also a lovely bonding time for mum and baby. And when a baby is feeding, it's actually encouraging the mother's body to release the hormone oxytocin. And oxytocin is making mums feel calm and relaxed. So feeding is not just nutrition, it's there for a really important reason. And the good news is when you put the work in, you will reap the reward. So when breastfeeding becomes established, you will find that the feeds become less frequent and the baby becomes more efficient at feeding. So it will all settle down. Another way to reduce challenges is to get off to a good start. In the Rotunda Hospital, we have policy that all babies are brought skin to skin as soon as possible after birth. That's in the event that mum and baby are well. And we try and get breastfeeding established as soon as possible. While in hospital, we ask that all mums learn how to position the baby and attach the baby to the breast. These are what we call the basics. And by having these right, you're reducing your risk of developing things like cracked nipples and engorged breasts. And we would say try and be sure that before you leave hospital that you feel confident and competent achieving these very basic skills. And I think the bottom line for anything is that if a problem is arising, say a cracked nipple or difficulty in latching, is that you seek help early. In the Rotunda, we have lactation consultants available Monday to Friday who are available for telephone calls. We have a breastfeeding support group on a Thursday morning, but also your local public health nurse and local support groups can be of help. So tongue tie, I've mentioned tongue tie because there's been a lot of talk about it in the media in recent years. And so what is it? Well, the frenulum is a string-like membrane that attaches the tongue to the base of the mouth. And if it is short or thick or tight, it can cause what we call a tongue tie. And this can reduce the mobility of the baby's tongue and can make it difficult for them to breastfeed. Now, the incidence of tongue tie is quite low. It's somewhere between 3 and 11%. And it's more common in boys than girls. So I suppose with management of tongue tie, the most important thing to say is that there are many babies that have a tongue tie and can breastfeed very successfully and don't need any interventions. But in the Rotunda, if we have a baby that is displaying symptoms of having difficulty with feeding, difficulty in latching or not thriving, we would have the lactation consultant assess that baby, and if necessary, we would have them assessed by a consultant paediatrician just to see if this is a tongue tie. If it is there, the baby may require what we call a frenotomy, and they can be referred for that. There's a website there that will give more information on tongue tie. So we're moving on to our next challenge postnatally, and this is urinary incontinence. And this is a much bigger problem than I think most people realise. So it's defined as leaking urine when you didn't mean to. And a recent Irish study, it's known as the MAMI study, it was conducted in Trinity College, has revealed that at 3 months postnatal, 1 in 2 women, that's 50% of women, leak some urine. And at 12 months postnatal, this was 2 in 5 women. So I'd like to begin by saying that urinary incontinence is not normal, because this study also showed that women actually felt that it was expected to have urinary incontinence after birth. So why does it occur? Well, the pelvic floor is a sheet of muscle, and its function is to support the contents of the abdomen. So when women are pregnant, they've got the weight of the baby, the fluid around the baby, the placenta, which is causing pressure on the pelvic floor. And also, the hormones of pregnancy are allowing this muscle to, I suppose, lack or sag even further, and the tone of the muscle reduces, and this is what leads to incontinence postnatally. So I suppose the first thing to say is that urinary incontinence can occur in women who have had either a vaginal birth or a caesarean section. Women who have vaginal birth, I suppose, have the added risk as the baby is being born that the pelvic floor divides, but it is not exclusive, and there are many women who've had caesarean section can have urinary incontinence. So what do we do in the hospital? Well, in the early days, we would have many women who would have some leaking of urine, and we would first of all exclude that the cause is a urinary tract infection. All women in the postnatal period are instructed to do pelvic floor muscle exercises. Usually the day after birth, you would begin them. If we have women who have a lot of urinary incontinence, or if urinary incontinence is persisting after 6 weeks postnatal, they are referred to the physiotherapist, and that would be for assessment and for a treatment programme. But as everything, prevention is better than cure. And the first thing I would say is that if you're considering a pregnancy, a healthy body mass index or a healthy body weight prior to pregnancy is beneficial. If you think that your pelvic floor is supporting the contents of your abdomen, if you are lighter, you're less likely to develop this problem. But also, pelvic floor muscle exercises prior to and during pregnancy and postnatally are advisable to reduce the risk of urinary incontinence. So in the Rotunda, we would actively promote pelvic floor muscle exercises for all our pregnant women, and we run pregnancy yoga classes, and a component of that is actually some pelvic floor muscle exercises. And on our website, on the Rotunda website, we have some educational videos, and they were designed with the MAMI study, and there are 4 videos which teach women how to do pelvic floor muscle exercises correctly. And another research study has shown that some women never do pelvic floor exercises before they become pregnant, and some women are unsure if they're doing them correctly. So that was a useful resource for everybody, and it can be accessed at www.rotunda.ie, and in the search bar, if you just pop in pelvic floor muscle exercises, you will get that information. So the last topic or challenge that I'm going to talk about this evening is the baby blues and postnatal depression. And I'm talking about both of them because I'd like everyone to really be able to know what the difference is between the two. So the baby blues, well, we would say that up to 80% of women experience the baby blues in the first few days after birth, and this is not considered a mental health concern. It usually occurs somewhere between 2 and 5 days, and the symptoms are tearfulness, anxiety, irritability. It is thought that it's due to the hormonal changes following birth, but also you've probably been in hospital for a couple of nights and not slept a wink. You're going home from hospital with a new baby. You're on a very steep learning curve, and you have levels of anxiety with regard to that. But these symptoms usually disappear with just some understanding and support. Postnatal depression is a different thing. And we would say approximately 1 in 10, in 2011 a study showed approximately 1 in 10 women will suffer from postnatal depression. But the MAMI study has also looked at a mental health stream, and they are saying that it is more likely that the figure is 1 in 6. So that's very high. So 1 in 6 women are suffering from postnatal depression. So the symptoms of postnatal depression, the difference here that this is at least a 2-week period of a depressed mood, loss of interest and enjoyment in life, an increase in tiredness, which sometimes would, normal adapting to parenthood, you would expect that, but also at least 2 of the following. So reduced energy, changes in appetite, pessimism, low self-esteem, sleep disturbances, or ideas of guilt or suicidal thoughts. So it can be quite a serious condition. Now, we know that there are some women who have a higher risk or higher chance of getting postnatal depression, and they are women who have a history of depression or anxiety in the past. If there's a family history of mental illness, and we would say particularly bipolar disease, not having friends or family support. And I personally think that this is a big issue. Years ago, when women were having babies, they had their extended family around them. They had mothers nearby, sisters nearby, and everybody came around to help with looking after this baby. Whereas nowadays, we live very much in nuclear families. We've got mum and dad and a new baby. And there are many parents who might not even know their next door neighbours because they moved into an estate and they go to work Monday to Friday and they come home with this new baby and they have no supports in the community. And it can be very isolating. Other contributing factors then can be financial or relationship problems, or if you've had a traumatic birth. But you don't have to have any of these risk factors to develop postnatal depression. So can we reduce the risk of postnatal depression? Well, within the Rotunda, if we have women who would see or perceive to have had any of the risk factors, they are referred to our emotional support team, and they're seen by this team during pregnancy and postnatally. We encourage all of our women to learn relaxation techniques, so we would actively promote things like pregnancy yoga classes and hypnobirthing classes. And we also encourage all the women to set up a support network. And that might be family and friends, it might be support groups like your breastfeeding support groups, but there are other support groups out there like mother and toddler groups. Postnatally then, we try and reduce the risk of postnatal depression. Now, we have a risk assessment tool that's not going to necessarily reduce postnatal depression, but at least we know the women who are at risk. And women who score high on this in the postnatal ward are referred to our emotional support team. And we also share this score with the GP and public health nurse, so they know which women will be at higher risk. And then we've really practical things. Sleep is so important. If you are really tired, it compounds everything. So sleep when your baby sleeps, eat healthily, get some exercise, and I think everybody needs to have realistic expectations of the challenges of early parenthood. Like any condition, early treatment or early recognition and treatment will lead to a quicker recovery. And we would say that you could attend either your GP. In the Rotunda, we would see women in our emotional support team with the consultant psychiatrist up to 6 weeks postnatally. The management may be just counselling, but you may require antidepressants. And women who do require antidepressants, we like to reassure them that the medications that we would use are suitable for breastfeeding mothers. So in summary, having a baby is an exciting time, but it does pose challenges. So we would encourage everyone to prepare for the challenge. Get good antenatal education, because knowledge is power. Attend your breastfeeding workshops. Do things like pregnancy yoga, hypnobirthing, eat healthily, learn how to power nap, and try and learn how to do this when you're on maternity leave. Get some exercise, set up your postnatal supports, have realistic expectations of the challenges ahead, and I think bottom line is seek help early if problems do arise, and the aim is really to enjoy your baby. So thank you for your time.